Hey class, welcome to the final module in grief and loss across the lifespan. We've covered a lot of topics this semester, looking at different types of grief, different theories of grief, different types of losses, and how those losses can intersect with where someone is developmentally in the lifespan. This last week, however, there is no more reading. I just want you to kind of focus on reflecting on the class this semester and getting in your final paper. But I always like to do a quick course wrap-up. Usually, I just kind of do a quick chat about the semester, maybe some things I learned and experienced. But something really interesting happened, and I wanted to give an update in this class since we didn't cover it at the start of the semester, and this kind of happened mid-semester. In March of this year, the DSM-5 released a revision including a brand new diagnosis they're calling prolonged grief disorder. Prolonged grief disorder, again, because it's in the DSM, that means it's in the Statistical Manual of Mental Health Disorders. It can now be diagnosed, it can be billed for treatment, and so we'll discuss some of those pros and cons. But what have psychiatrists, psychologists decided qualifies as grief that then requires additional treatment? They've decided that adults who have been severely bereaved for 12 months or more, or 6 months or more for children and adolescents could qualify. In addition to that timeline, there has to be, the bereaved individual must experience or can experience several symptoms, including intense longings for the deceased, preoccupation with thoughts of the deceased, so it's constantly on their mind. Or in children or adolescents, children can often be focused on more of the circumstances around the death as they're kind of, existentially adapting to the reality of death. These grief reactions, again, are supposed to occur most of the day, nearly every day, for at least a month. But again, that loss should have been at least 12 months ago for adults or 6 months ago for children and adolescents. The individual should be experiencing what they call clinically significant distress or impairment in social, occupational, or other areas of functioning. What does that mean? It means that those feelings of grief are getting in their way of connecting with other people, of doing their jobs, of going out in society, of engaging in hobbies, etc. When we think about what makes depression clinically significant, it's kind of similar to that. When does sadness become depression? So when does grief become impairing? It's when it gets in the way of you living your life the way that you would ideally want to. Now notice that they're talking about bereavement with grief, so they're only still thinking about grief through that lens of death. I do think we have the strongest reactions, of course, when we lose loved ones to death, but I'm still interested in how we are going to provide support and treatment for people beyond that. Here's some more of the symptoms. Some of the symptoms of the prolonged grief disorder are identity disruption, which we've talked about. When we lose something that is really important to us or someone, we often lose a piece of ourselves. We lose something that kind of informed who we were, so we can feel like a part of ourselves has died. A disbelief about the death, avoidance of reminders that that person has died, intense emotional pain, of course, that we know can come along with grief, difficulty moving on with life, emotional numbness, feeling that life is meaningless, and intense loneliness. Now, we know that grief is a universal human experience, and we know that grief happens throughout the lifespan. It happens in a lot of different ways, and of course, again, this is focused on bereavement. What are some of the off-the-bat pros and cons of this kind of being added as a mental health disorder that could be billed and treated? Pros and cons. So the first kind of apparent pro is that clinicians can bill insurance companies to treat prolonged grief, meaning that people who are really, really struggling, if they are experiencing grief that is devastating and getting in the way of them kind of living a fulfilling and meaningful life, they can go get treatment, and that can be covered through insurance. And we know that in our society, without insurance coverage, you often can't get help. This will likely lead to more funding for research into treatments for grief, and will reduce and can help reduce providing treatment is thought to hopefully reduce some of the negative outcomes of prolonged grief, such as increased rates of suicide and significant health issues. We know that grief has a huge impact on the body, so things like high blood pressure, that, hoping that if we can attend to prolonged grief, people who are experiencing intense grieving, that we can reduce those negative outcomes. What are some of the cons off the bat? Well, at the same token, I think clinicians billing insurance companies to treat prolonged grief is also a con. Why? Because insurance companies sometimes dictate what does and does not deserve treatment, and I'm not sure that insurance companies should really have that power. We also think about, are clinicians going to be more likely to give a grief of diagnosis so that they can get reimbursed, whether or not that patient or that client, as I would call them as a counselor, really meets the criteria? Does that person really need to be diagnosed with a mental health disorder? And that leads into pathologizing grief. Mental health disorders in their first inception were meant to kind of be a way of talking about behaviors and experiences that maybe are a little bit beyond the norm, that might need particular attention, but grief is something everyone experiences. So there's kind of a fundamental tension between what grief is and a lot of elements that make a mental health disorder. This is a huge one, the risk of relying on medications to treat grief. Because here's the truth. As a counselor, I cannot prescribe medication, but I am heavily trained in how to do individual, group, family therapy, how to do that one-on-one process of working with someone to make meaning of their experiences, which we know is a core feature of working through grief. However, when you talk about a lot of mental health professionals that are out there, particularly psychiatrists or psychologists, they do heavily rely on medication. General medical doctors could diagnose people with prolonged grief disorder, and I guarantee you they're going to be giving people meds. They're not going to be necessarily referring people to therapy. There's a lot of research that shows that doctors really underutilize referrals to counselors and mental health therapists who are going to do more ongoing mental health therapy, which is very appropriate for grief to do that. As I said, risk of premature diagnosis. We know that grief is complex, it is nuanced, and it is not something that lends itself to quick and easy diagnosis to say, again, when is this really deserving of specialized treatment? So that is a risk, and as I said before, many people argue that grief is not a problem to be solved, but a process to be lived through. The New York Times has done some really excellent reporting on this topic, and I'm going to post a link that can show you how to actually access a couple New York Times articles on this topic if you want to check them out. We have access to the New York Times through our library, which is pretty rad. But they wrote this article about it, and then there was an opinion piece, and I wanted to just kind of quickly go through some of the opinions that people sent in when they read this article, that, psychiatrists have decided that a year is the timeline for grief becoming severe enough to deserve to need medical treatment or to be a mental disorder. So this was on March 19th, so the front page, in response to an article that was posted on March 19th. It is more than 6 years since my wife died. I balk at reframing prolonged grief as a mental disorder. It is not depression, not merely an emotional state that one passes through to emerge on the other side as one was before. Grief is transformative, and I am not the same person I was before my wife died. And I'll leave it there for a moment so you can read. I'm not going to read through all of these, but I'll end with, the cliche that everyone grieves in his or her own way is assuredly true. That the psychiatric establishment has now pathologized prolonged grief is not only stigmatizing, but also imperious. When they develop a pill that will bring my wife back, I will reconsider my position. Here's a more supportive opinion from an individual in New York who is a rabbi and pastoral counselor. Snap out of it is a fairly accurate description of the American attitude towards grief. However, mourning is a complex and individual process. The length of time one grieves is determined by many factors, including the nature of previous losses. There's a difference between mourning over a long period of time and a state of being in which one is unable to resume normal life. The new Diagnostic Statistical Manual of Mental Disorders diagnosis of prolonged grief disorder is a healthy step towards defining and validating the emotional complexity of bereavement. The comparison to trauma noted in this article is very apt. Trauma is a state of being that most people recognize as being not normal, an emotional state that requires treatment. Bereavement is a particular subset of trauma. This new diagnosis validates the experience of those who struggle with living their lives after loss. It also provides important financial tools for those wishing to seek treatment so that they can recover joy in living. A couple more. Here's one from someone else in New York. Unfortunately, each new DSM diagnosis opens up the floodgates for a new group of suffering people to treatment with psychiatric medications. As an internist psychiatrist with 30 years of experience treating end-of-life patients and their families, I've witnessed psychiatry reduced to viewing all human suffering as a set of pathological disorders or diagnoses that must be treated with drugs, fallaciously touted as curing everything. Make no mistake, medical treatment means only one thing: drug treatment. Despite Dr. M. Catherine Shear's psychotherapy program at Columbia, which her report was found to be more effective treatment for prolonged grief than antidepressants and other depression therapies. Bereaved, beware. And in that, referring to in the original article, they discussed that a lot of the most kind of valid, effective treatments for grief we found do tend to be psychotherapy. They tend to be whether that's groups or individual therapy with a counselor or counseling psychologist. Again, it's that process of making meaning of grief that does tend to be effective, but there are a lot of concerns, again, that a lot of medical providers and mental health providers might overly rely on drugs. And I'll read one more. I've specialized in grief over the past 40 years as a practicing psychologist. Regarding the DSM-5's new prolonged grief diagnosis, I rejoice at the new options for help that this diagnosis opens up. I am dismayed, though, that in our profoundly dysfunctional medical model of psychotherapy, the grief process must be pathologized in order to access treatment funding. This causes sufferers to distrust and disavow their painful feelings. The best way to help with prolonged grief is the opposite: to honor these feelings and to explore what purpose is served by them in the client's psychological system in order to find other, better coping strategies. From Peter Hunsberger. So those were a few opinions, and certainly in the discussion board this week, I am interested in your opinion on having prolonged grief disorder in the DSM being something that people can go get formalized treatment for. But to just quickly wrap up, this is a class that I really love to teach. When I was first designing this class, it was before the COVID pandemic, and so through the last couple years, this class has become all the more salient and meaningful in providing people language and space to think about the many types of losses and how we respond to losses, and also how losses transform us. Pain is scary to sit with, but it also teaches us so much about who we are, what is important to us, what kind of lives we want to live. This is something I thought about a lot this semester in losing my cat Hex. I thought a lot about how he made my husband and I a family for the first time, how he was with us through the harder first rocky years of our marriage, how he taught us to be kinder to ourselves and taught us to find joy and sweetness in everyday life. And though he's gone, that's something I want to carry into. And I found myself thinking a lot about the models that we talk about. I thought a lot about the dual process model and even actually the 5 stages of grieving, though I often don't think about that. It was helpful for me in my grief process and thinking, how do I go through this pain in a way that is productive and helpful to me? And I hope that this class provides that for you, that through your life, I certainly want to train helpers here, but first I want us to be able to help ourselves. I hope that these models and this content has given you space to normalize your pain and your grief experiences, and hopefully gives you some amount of support when you're there, because we are all going to grieve. Grief is a part of life, and I appreciate you going to those places with me this semester. I hope that you have more of a tolerance to sit with pain, to reflect on pain, and to go there with others, because it is going to make a big difference. I think that in the future, it seems like there are a lot of things that are causing loss and grief in our society and truly around the world. And we need people who can be aware of that and sensitive to that and not afraid of it. So again, thank you, and head on over to the discussion board. Have a great last week and a great summer, you guys. Bye.